Hi and welcome. So today we are going to talk about abnormal labor, and specifically we are going to look at the prolonged first, second and third stages of labor, and we shall look at how to manage them. Before we can define abnormal labor, a definition of normal labor must be understood and accepted. And so, labor is a physiological process during which the fetus, membranes, and umbilical cord, as well as the placenta, are expelled from the uterus. And so, with the onset of labor, we mean we must have a regular painful uterine contractions which occur every 4 to 5 minutes and must last for about 30 to 45 seconds, leading to cervical effacement and dilatation. By cervical effacement, I mean the taking up of the cervix into the lower uterine segment, and dilatation is opening of the cervical os. Now, there are three important components of this labor, which we have grouped into the three P's, where the first P represents the power. Power is the strength with which contractions and retractions of the uterus occurs. Contractions here refers to the temporary shortening and thickening of the muscle fibers in the active phase of labor, and retractions is the permanent partial shortening of these muscle fibers. Now, these contractions and retractions must be regular, rhythmic, and with increasing frequency and duration. Now, the second P talks about the passages or pelvis, which is the birth canal and the bony pelvis, as well as the pelvic floor muscles through which the baby passes to be born. And the third P talks about the passenger, that is the fetus itself. Now, any alteration in these three P's will lead to an abnormal labor, and so we shall spend some time to discuss them in detail. But before that, let's recap our knowledge in normal labor. Now, we said stages of labor. We have the first stage of labor, which is up to 10 centimeters dilatation or full dilatation of the cervix. Then we also talked about the fact that we have the latent phase of the first stage of labor, which is from 3 to 4 centimeters or up to 3 to 4 centimeters dilatation, and must last for between 15 and 20 hours in the primipara, as well as 12 to 14 hours in the multipara. Then we talked about the active phase, which is from 3 to 4 centimeters to full dilatation of the cervix with rapid dilatation at this stage, and it must be followed by the cardinal movement to deliver the fetus, usually lasting between less than 5 and 6 hours in the primipara, as well as between 4 and 5 hours in the multipara. Now, the second stage of labor talks about the expulsion of the fetus, which lasts within up to 2 hours in the primipara and also 1 hour in the multipara. Then also we saw the third stage of labor, which is the delivery of the placenta, and it must be within 30 minutes for both primipara and the multipara. Then we looked at the fourth stage of labor, which is from 2 hours, postpartum. Now, when we fail to meet these criteria, then abnormal labor is present, which suggests an increased risk of an unfavorable outcome. And so we must look for alternative methods for a successful delivery that minimizes risk to both the mother and the baby. Now, we are going to look at the indicators of abnormal labor. And so, when we pick the prolonged latent phase, it is when it lasts for more than 20 hours or more than 14 hours in the primipara and multipara, respectively. And a prolonged active phase is when it lasts for more than 6 hours in the primipara and more than 5 hours in the multipara. Now, the rate of cervical dilatation in the active phase must be calculated. It is important because it will help us to determine if labor is prolonging or not. For instance, if the woman presents with 5 centimeters dilatation and after 2 hours you check and she is 6 centimeters dilated, it means that cervical dilatation increased for only 1 centimeter. And so we divide 1 centimeter by 2 hours and we are getting 0.5 centimeters. Now, this indicates a delay in the active stage of labor because, as we've seen, the active stage of labor must be between 1.1 to 1.2 centimeters dilatation per hour in the primipara and 1.2 to 1.5 centimeters per hour dilatation in the multipara. Now, on the other hand, if the woman presents with 6 centimeters dilatation and after 2 hours she's 9 centimeters dilated, it means we've had 3 centimeters dilatation in 2 hours. When we divide 3 by 2, we are getting 1.5 centimeters per hour, which is very good because the rate of cervical dilatation in the primipara is what we've seen. And so any dilatation which is below 1.1 centimeter per hour in the primipara and less than 1.2 centimeters per hour in the multipara is classified as a delay, which will lead to a prolonged active phase of labor. Also, when we look at the protracted descent, any descent which is less than 1 centimeter per hour in the primipara as well as less than 2 centimeters per hour in the multipara is classified as a delay, and it is going to lead to prolonged active phase. Now, in the second stage of labor, if the woman is given regional anesthesia, then second stage of labor lasting more than 3 hours in the primipara and more than 2 hours in the multipara is said to be prolonged. And if the woman is not given any regional anesthesia and second stage lasts for more than 2 hours, we say it is prolonged. And if it lasts for more than 1 hour in the multipara, we say this is prolonged second stage of labor. Then in the third stage of labor, it must last for 30 minutes for both primipara and the multipara. And so any third stage which lasts for more than 30 minutes in both primipara and multipara is said to be abnormal. Now, let's look at the various phases in detail. So labor lasts for more than 8 hours without entering into the active phase or into the active stage of labor in prolonged latent state. And over here, what we find is that the cervix is less than 4 centimeters dilated for more than 20 hours in the primipara and more than 14 hours in the multipara. And the causes of prolonged latent phase include iatrogenic causes, such that when we give epidural anesthesia or analgesia to reduce the pain of labor, or even sometimes when we give narcotic sedation, all of these come together to cause poor efforts by the mother, and so it delays the contractions, or it reduces the contractions of the uterus, which will lead to prolonged latent phase. Then also we have inadequate uterine contractions, which may be either hypertonic or hypotonic. With hypertonic uterine contractions, the contractions are strong, but they are short in duration. And in hypotonic uterine contractions, the contractions are weak and infrequent, and so they cannot lead to dilatation of the cervix, leading to prolonged latent phase. So how do we manage the prolonged latent phase? We have to rule out any Braxton Hicks contractions or forced labor. How do we do this? We have to first give morphine IV to reduce the pain and also the abnormal uterine contractions. And if the contractions stops, then it is Braxton Hicks or forced labor. But if contractions leads to dilatation, then we say this is true labor. Now, we must also make sure that the bladder is empty at all stages of labor, since a full bladder will interfere with uterine contractions. Now, with prolonged active phase, what we said is that labor is lasting for more than 12 hours without entering into the second stage of labor. And the causes of prolonged active phase include the power, the passenger, as well as the passage that we talked about. And so with the power, we may find inadequate uterine contractions, just as I explained before. And so the uterine contractions may be weak, or they may either be strong but very infrequent, and this cannot cause dilatation of the cervix. Also, we are going to have the passage when there is disproportionate pelvis in relation to the fetal head. Then also we are going to have the passenger when it is big, or when we have a big baby, or abnormal positioning and presentation of the baby. All of these can come together to prolong the active phase. I'm going to spend some time to explain this in detail as we move forward. And so, how do we manage the prolonged active phase? We have to determine if the power is hypertonic. We can give morphine, as we did earlier on, to reduce the pain and relax the uterus, and see if dilatation will ensue. Then, if we determine that it is hypotonic, then we must stimulate the uterus to contract by giving oxytocin. Then, if it is normotonic, then we have to go in for cesarean section, because there is actually no hypertonic or hypotonic or excessive or abnormal uterine contraction, just that dilatation is not taking place. So we have to go in and do cesarean section for this woman. Now, if we determine that the cause of the prolonged active phase is as a result of the passage, there is absolutely nothing we can do about the passage or the birth canal. We cannot increase it. So we have to go in and do cesarean section. And if we determine that the problem is coming from the passenger, which is the baby, for example, if there is abnormal presentation, then we may try doing external cephalic version to align the baby with the maternal pelvis. But if we fail in external cephalic version, we have to go straight to do cesarean section for this woman. Now, when we talk about arrest of labor, what we mean is that cervical dilatation is more than or equal to 4 centimeters with rupture of membranes, and one of the following: we must have at least 4 hours or more of adequate contractions with a Montevideo unit of 200, or 6 hours or more of inadequate contractions and no cervical changes. This is what is the definition of arrest of labor. Now, when we look at the management of arrest of labor, we have to determine whether it is hypertonic or hypotonic or normotonic, just as we managed in the active phase. And so if it is hypertonic, we give morphine, and if it is hypotonic, we give oxytocin to stimulate contractions, and if it is normotonic, then we have to go for emergency cesarean section. Now, what are some of the complications of prolonged first stage of labor? We find that there is a higher cesarean section rate. Then also it may lead to chorioamnionitis, which is infection of the amnion and the chorion. Then also we may have prolonged second stage. Once the first stage is prolonged, it will definitely lead to a prolonged second stage of labor. Then also we may have maternal fever, then shoulder dystocia in the baby. Then we may also have increased neonatal ICU admissions. These are some of the complications of prolonged first stage of labor. Now, with prolonged second stage of labor, we define it by first defining obstructed labor. And so obstructed labor is the failure of the fetus to descend through the birth canal because there is a barrier or an obstruction which is preventing its descent despite strong uterine contractions. And these obstructions usually may occur at the pelvic brim, the cavity, or sometimes at the outlet. And it is prolonged second stage when it lasts for more than 1 hour in the multi-gravid or the multiparous woman, or more than 2 hours in the premi-gravid woman or the premi-parous woman. Now, although labor can be classified as prolonged at any stage of labor, you must note that obstructed labor most commonly develops after the labor has entered into the second stage of labor. Now, the causes of obstructed labor are due to the 3 P's, and so we shall look at the passenger, the power, as well as the passage. When we pick the passenger, the baby is traveling down the birth canal, and prolonged labor may occur if the fetal head is too large to pass through the maternal pelvis, or the fetal presentation is abnormal. And so when we look at the fetal head size, it may be so large as in cephalopelvic disproportion. Cephal represents the head, and disproportion tells you that the size of the fetal head is different from the size of the maternal pelvic brim. And what this means is that it is going to be difficult or impossible for the fetus to pass safely through the maternal pelvis, either due to the maternal pelvis being so narrow for the fetal head, or a large fetal head relative to that of the maternal pelvis. An important thing that we must note over here is cephalopelvic disproportion cannot be diagnosed usually before the 37th week of pregnancy, because before then the baby's head has not reached the birth size. Now, another abnormality that we may find is hydrocephalus, where there is excessive accumulation of fluid around the baby's brain, making it bigger for the maternal pelvis. And also, we may also have a big baby. Obviously, if the baby is big, it cannot even enter into a normal pelvis to be delivered. Then we may also find malpresentations and malpositionings. Any presentation other than the vertex is malpresentation, and the most common presentations which are classified as abnormal are the breech presentations, in which sometimes the baby comes with the buttocks or even the feet first, and sometimes even the shoulder. Now, malpositioning is when the baby's head is down, that is in the cephalic presentation, but in a wrong position relative to the maternal pelvis. Now, when we look at persistent occipitotransverse, the fetal head lies in the transverse diameter of the maternal pelvis for 1 hour or more into the second stage of labor, and this will lead to arrest of descent. Twin gestation may also cause obstructed labor, especially in locked twins. What happens is that the two babies are locked together at their necks when the first twin is in breech presentation and the second twin is in the cephalic presentation, or even when we have conjoined twins where the twins are fused at the chest or at the head or any other site. Now, there is another factor which is asyncletism, and this is when there is oblique malpresentation of the fetal head. What happens is that the head is presenting all right, but it's tilted to the shoulder, causing the fetal head to no longer be in line with the birth canal, leading to failure to progress. Now, with power. Inadequate power due to poor or uncoordinated uterine contractions is a major cause of prolonged labor. It's either the uterine contractions are not strong enough to efface and dilate the cervix in the first stage of labor, or the muscular effort of the uterus is insufficient to push the baby down the birth canal during the second stage of labor. And for uterine contractile force to be considered adequate, we must have a Montevideo unit of more than 200, and so any Montevideo unit which is less than 200 during a 10-minute contraction period is said to be abnormal. And so the contractions should be strong enough. And so when we have hypertonic or hypotonic contractions, whereby the contractions are either strong or short in duration or weak, and infrequent, in duration, then we are going to have an obstructed labor. We may also have cervical dystocia, which is a difficult and prolonged labor, which is caused by a mechanical obstruction at the cervix because the cervix fails to dilate despite adequate uterine contractions. Now, when we look at the passage, labor may be prolonged if the mother's pelvis is too small for the baby to pass through, or the pelvis has an abnormal shape, or if there is a tumor or other physical obstructions in the pelvis. And so we may have contracted pelvis, which may be due to malnutrition, or deformed pelvis, which may be due to either trauma or infections such as polio. Now, the contracted pelvis may either be anatomical or obstetric. And in anatomical contracted pelvis, it is when we have one or more of its diameters being reduced. And in an obstetric contracted pelvis, it is when we have one or more of its diameters reduced so that it interferes with normal mechanism of labor. Then we may have soft tissues in the pelvis, as I've just explained. For example, if we have a growing tumor in the pelvic cavity, or a scar from the birth canal due to a severe form of genital mutilation, or if the mother have a tight perineum such that it is unable to distend and allow for the baby to be delivered. All of these may obstruct labor. And so on this image, you can find that the pelvis of this mother is too small for the baby's head. And so this is an example of a cephalopelvic disproportion. Then over here, we have the left occipital transverse positioning of the fetus. So you can see that the fetal head lies in the transverse diameter of the maternal pelvis. Then also we have asyncletism, where the baby is lying in an oblique manner with the shoulder also presenting over here. Then we have the locked twins. So you can see that the first twin was being delivered in the breech presentation, and the second twin is coming down in the cephalic presentation, and so their head is locking each other over here. And this will obviously lead to an obstructed labor. Then when we look at these images, we have the gynecoid pelvis over here, which is the preferred pelvis for the woman, because it has adequate room. You can see that the ischial spines are rounded, not projected, and we have a wide anterior-posterior diameter. And so you can see that it is very roomy for the baby as compared to the android, the platypeloid, and the anthropoid pelvis. Also, on this image, you can find a growing tumor, which is entering into the pelvic cavity, and obviously this is going to reduce the space for the descent of the fetal head, leading to obstruction. A key sign is when the widest diameter of the fetal skull remains stationary above the pelvic brim. Now, when we look at this image over here, we discussed that the fetal head must pass through the pelvic brim, enter into the cavity, then gradually enters into the outlet to be delivered. This should be the normal process. Now, any problem which causes the fetal head not to descend into the pelvic brim is going to point to an obstructed labor. Now, how can we determine this? We can determine this by carefully palpating the mother's abdomen as the uterus relaxes and softens between the contractions. However, if the uterus has gone into a tonic contractions, that is, if the contractions are continuous, making the uterus hard, it will be tightly molded around the fetus, and so it will be very difficult for us to feel whether the fetus is making any progress in the birth canal. And palpation will also be painful for the woman, and so in this case we must rely on other signs to diagnose this obstructed labor, some of which include the fact that the labor has prolonged for more than 12 hours. Then also we may find that the mother appears exhausted and anxious, and also the woman feels weak. Then also we may realize that there was a premature rupture of membranes. Then there's going to be abnormal maternal vital signs, and so there's going to be tachycardia, blood pressure is going to drop. Also, there's going to be tachypnea of more than 30 cycles per minute, and there is possible fever in this woman. At this point, you should assess the woman by doing a vaginal examination. Any of the following additional signs will also suggest obstructed labor in this woman. Now, these other signs may include a foul-smelling meconium from the vagina. We may also have a concentrated urine with either meconium or blood. Then also we may find edema of the vulva and the labius. And when we do vaginal examination, it feels hot and dry, which may indicate that the woman is dehydrated. And also we may find, edema of the cervix. We may also find caput succedaneum, which is a swelling around the fetal skull due to excessive pressure on the baby's head. Then there may also be malpresentation and malpositioning of the fetus. Then we may also find a poor cervical effacement, whereby the cervix, feels like an empty sleeve, and so you may still find that the cervical canal, is still there. Then we may also detect what we call the Bandel's ring. I will explain what the Bandel's ring means, but before that, I will explain what is a retraction ring. Now, as the uterus contracts in labor, the upper uterine segment becomes shorter and thicker, whilst the lower uterine segment becomes thinner as it dilates. And so, the harmonious opposing actions of the upper and lower uterine segment is what we call the polarity. And the junction which is created between the upper and the lower uterine segment is what we refer to as the retraction ring. Now, looking at this photo, we find that there is a mild depression on the maternal abdomen, which is abnormal. And it is important for us to note that the retraction ring should not be visible on inspection or even on palpation of the abdomen. And so anytime we find such a depression, it is abnormal. And this is what we refer to as the Bandel's ring. Now, when labor prolongs and there is excessive opposing muscle action between the upper and the lower uterine segment, then there is the creation of a depression between the upper and the lower halves of the uterus at about the level of the umbilicus, which is usually visible, on inspection, and also we can palpate it. And this is what we refer to as the Bandel's ring. And it is a late sign of obstructed labor, and it also indicates an impending uterine rupture. Now, when we look at the image over here, in A, we find the normal shape of the abdomen, but in B, we find that the retracted upper uterine segment, over here. Then we find the distended lower uterine segment also over here, which is separated by the Bandel's ring, which is the depression as we find over here. And this is abnormal. Also in this photo, we find that there is, a grossly thickened upper uterine segment which is retracted towards the mother's ribs, and also we find below the ring the distended, dangerously thinned lower uterine segment over here, and this is abnormal. When you find this, you must urgently go into do cesarean section. Now, when we look at the image over here, we find that in cesarean section, there is the Bandel's ring over here, and actually this uterus was nearly, rupturing, as you can find in this image. And you can find that the bladder is bruised over here because of extensive pressure of the fetal head on the bladder, as you can see. Now we can use the pathograph to determine obstructed labor because it is a graphical tool which we use to assess the progress of labor. And so anytime labor is being delayed or there is any abnormality, we should be able to detect it from the pathograph. I have a separate video on pathograph which you can watch, but in this video I'll use just this graph to demonstrate how we may have obstructed labor. And so we have the cervical dilatation over here. So the woman came in 5 centimeters dilated, and after some hours what we found was that the cervix dilated till it got to 10 centimeters dilatation. And so we realized that the dilatation or our plot did not cross the alert line over here, which is normal. The plot should not cross the alert line. Also, we find that there was descent of the fetus, and so as you can see, it started from this side and it ended over here, which corresponds to the time at which the mother had 10 centimeters dilatation of the cervix. And so this indicates a good prognosis, or this indicates a good descent of the fetus. However, when we compare it to the B over here, we realize that the alert line is here, but the cervix stopped dilating 4 hours after the pathograph recording began. And so our plot started, crossing the alert line and even entered into the action line. Anytime your graph begins to cross the alert line, it tells you that there is an abnormality, and so you must take action before it even reaches the action line. Also, we find that there was no descent of the fetal head over here. So you can see there is a straight line without any descent as compared to the first one. And so this is how we use the pathograph to determine if labor is prolonging or if there is any abnormality. Now, how do we manage obstructed labor? Now, if you determine that there is a sign of shock in this woman, then immediately you must set, large bore cannulas with either size 18 or 20 cannula and infuse this woman with IV fluids, normal saline or Ringer's lactate of 1 liter, and repeat after every 20 minutes until the pulse slows to about below 90 beats per minute, and the diastolic blood pressure comes to about 90 millimeters per mercury. Now, you also have to determine if the obstruction is due to a full bladder. Then you must insert a urinary catheter to drain it. And usually, relieving this obstruction may be enough to allow the baby to be born. And it is important for us to note that catheterization at this stage may be very difficult because the urethra is also obstructed by the deeply engaged baby's head. And so you need some expertise and some skill in order to pass the catheter. Then you have to determine if the problem is coming from power. Then you must determine, is there inefficient contractions of the uterus? If yes, then you must give oxytocin to stimulate uterine contractions. And you have to determine if it is efficient, then you must palpate the fetal head to assess for engagement. If there is engagement, then you must try forceps or vacuum delivery. But if there is no engagement, then you must go in for emergency cesarean section. Now, if the problem is the passage, there is absolutely nothing we can do with the birth canal, and so we must go in to do cesarean section. We cannot open the birth canal. Now, we also have to assess if the problem is from the passenger, that is the baby itself. For instance, if it is due to abnormal lie or presentation, then we can try the external cephalic version. But if it fails, we must go for cesarean section. Now, what are some of the complications of obstructed labor? The commonest complication of obstructed labor is formation of fistula, and this fistula may occur between the vagina and the urinary bladder, sometimes also the vagina and the rectum. Then we may also have it between the vagina and the urethra and the vagina and the ureter. Now, as a result of this fistula, urine or feces get into the vagina and exit in an uncontrolled way. A woman with a fistula can leak urine or feces whilst walking or even doing her daily activities, and these may even stain her clothes and create bad smell. Because of these effects, her husband and family members may even stigmatize against her or even make her an outcast. This is how serious this complication is. You can imagine what continuously leaking urine or feces mean at the personal level. And so it is important for us to understand how this complication occur and how we can prevent it to avoid some of these consequences. Now, as a result of this fistula, these women may even get depressed, and they may even have some physical illnesses and infections of the reproductive tract, including the bladder and the kidneys, which may even result in some women taking their own lives. And it is estimated that about 20% of all cases of fistula, in these women is as a result of obstructed labor. And so this is how grave this complication is. And we must do everything possible to prevent such complication. Now, we may also have postpartum hemorrhage as a complication. Then we also have a slow return of the uterus to its pre-pregnancy size. Then also, we may have these women going into shock because they've lost a lot of blood and fluid. Also, they may be paralytic ileus because the intestines have become paralyzed, and so substances cannot move down the gut. Then we may also find septicemia, or sepsis in these women. Then, unfortunately, we may even find death in some of these women. Now, there are some complications which are found in the neonate, and they include the neonatal sepsis. We may also find convulsions in these neonates. There may also be, facial injuries and other injuries. We may also find shoulder dystocia. We may find, the Erb's palsy. We may find even cranial injuries, in these babies due to prolonged and obstructed labor. And there may also be severe asphyxia in these babies, and unfortunately, they can even die out of this. Now, prolonged third stage of labor is when the placenta has not been delivered together with its membranes within 30 minutes. Some of the causes of prolonged third stage include atony, and with atony, the uterus does not contract strongly enough to separate or expel the placenta completely. We may also have full bladder, as I explained. When the bladder is full, it prevents the uterus from contracting and causing the separation of the placenta. Then also we may have abnormal placentation in the form of placenta accreta, increta, and pacreta. And in these cases, it is obvious that the placenta is deeply embedded into the muscle layer of the uterus, and it is obviously not going to be expelled spontaneously. And so, how do we manage the prolonged third stage of labor? We have to make sure that the bladder is empty at all times. Then we have to give IV fluids with 20 units of oxytocin in 1 liter of normal saline. Now, we have to make sure that the uterus is contracted. Once the uterus is contracted, we can try again to deliver the placenta by controlled cord traction. And so we must continuously stimulate the uterus to contract. It is very, very important for us to ensure this because it is going to reduce the risk of postpartum hemorrhage. Alongside, we have to check the blood pressure of this woman every 15 minutes and make sure that we keep this woman nil per os, because there may be the likelihood that this woman will go to the theater for an operation to remove the placenta. And so we may also do manual removal of the placenta under general anesthesia, or we can even do instrumental revision of the uterus to try to bring